Thanks everyone for joining this week for virtual spine. This week we got the honor of having my friend Hanjo Kim, who's an orthopedic surgeon at the Hospital for Special Surgery in New York City. Have had the pleasure of getting to know Hanjo through our work together in the ISSG. I was very grateful that he shared his time with us today. The topic today is some of his complicated deformity cases. He knows that the goal is to be really interactive, so feel free to chime into the chat box with any questions or criticisms of Dr. Kim's work. And Hanjo, you should feel free to call on anyone. I think basically almost everyone who's showing a video is a host or a panelist for our virtual spine conference. So feel free to pick on people, especially Dr. Galgano.
Great. Thanks for the intro, Coy. So first I want to send a big thank you to all the hosts, especially Ali Baj and Dr. Then, for giving me this opportunity to present, and Dr. Shin and Dr. Galgano and Dr. Memigani, and the list goes on for the hosts. But really, it's a real honor to be here today, and I hope we could have a fruitful session here for the next hour. So I've been asked to give a talk on going over some complex deformity cases for today's conference. Here are my disclosures. So this is what I'd like to do today. I want to go over about 4 complex deformity cases. I want to discuss my thought process in a very open way. And just like Coy had said, if any point in time you have something you disagree on, or you want to debate about, or you want to discuss, I'm very open to the interruption. So please, I encourage all of that. I think that's how all of us could really learn. And then after each case, I want to provide 1 to 2 take-home points that everybody else who's listening at home, I think we have 40 or so participants right now, could use them in their next case, or at least think about it, or think about incorporating it into their practice as far as their surgical technique and plan. And then want to answer any questions for you guys as openly as possible. Feel free to ask me about complications. So here's case number 1. And this is a case that Dr. Baj had referred to me. Actually, we logistically had tried to do it together, but because of the issues between New York Hospital and HSS, we eventually were unable to do it. But this is a 60-year-old lady who had significant back pain and no leg pain at all. But really her issue was the inability to stand upright. So you could see here on the standing AP and lateral X-rays, she basically has what I would call a severe coronal and sagittal plane decompensation. So when I evaluate these patients, I usually start out with standing radiographs like this, but more and more, I'm also utilizing X-rays that go all the way down to the feet. And the reason why is because it's not uncommon for these patients to also have concurrent pelvic obliquity, hip or knee pathology, or even ankle pathology. Let's say they have a varus or valgus deformity at the knee. All of these things could affect the pelvic obliquity and will change the surgical plan depending on whether or not it's a leg length discrepancy or a pelvic obliquity that's coming from a leg length discrepancy issue that's going to be eventually addressed later on, or something related to the spinal deformity. The supine X-rays are really helpful also. So this patient's supine X-ray, you can see it's pretty rigid in the coronal and the sagittal plane. There's persistent kyphosis. You could see that there's also persistent coronal decompensation. The rib is here now articulating with the left-sided iliac crest. And I could tell you that when I look at a supine radiograph like this, what it tells me is that I'm probably going to need an osteotomy. I did get a CT scan on this to confirm that there were no autofusions. And sometimes in adult spinal deformity, it's very common to see the lumbar apex being autofused for 2 or 3 segments above and below the apex. And then I also got an MRI, which did not demonstrate significant stenosis distally. So my thinking process here in a case like this is, okay, what levels am I going to choose? Am I going to go down to L5? Am I going to go to S1? If I go to S1, am I going to place iliac fixation? And my thinking here is that you got a lady who's in her 60s. The bone quality is probably not going to be optimal. If I'm doing a large reconstruction, I'm probably going to go to S1 in the ilium. As far as the upper instrumented vertebra, could I go short or do I go long? So do I go upper thoracic versus lower thoracic? And in this case, because of the large magnitude of the coronal and sagittal plane deformity, I'm probably going to go high. Now the MRI is useful for the thoracic spine because you could see here whether I stop at T3, T4, or T2, it's dealer's choice because there's no significant degeneration at these segments. But my purpose of getting an MRI of the thoracic spine for these patients is to really look at whether or not the planned UIV has a pre-existing degeneration that will not allow me to stop there. As far as osteotomy selection, the question is, do I do SPOs or do I do a 3-column osteotomy such as a PSO or a VCR?
Hey, Hancho, maybe this is a good time to poll some of the folks who do a lot of deformity, like Dr. Goodwin, Galgano, et cetera, and see kind of what their thoughts are and what they do. Any takers?
Yeah, Hanjo, I'm curious if you get bolster films on these people. Obviously, she's got this kind of gibbous deformity at the upper lumbar, thoracolumbar junction here. Would you get some type of bolster film here to see how flexible that is?
Usually I do not get bolster films, and the only reason why is because of the radiology technicians. It would be a nightmare. I would have to send somebody down to make sure the bolster is placed in the exact right place. And the only time that the radiology techs are able to replicate it in a decent way, for us at least at HSS, is with the pediatric population. So what I do instead is I get these supine X-rays, but what I do in the office, I have them lay prone on the table, and I do push on their rib hump, and I see how much their deformity moves. That gives me an idea on how much flexibility that I could expect intraoperatively on the operating room table.
Yeah, so I think I'm very excited to see what you did. I think to your advantage here, you have a deformity that does correct significantly when the patient's supine. You also have, to your point, no autofusions and lots of mobile sort of disc spaces at your advantage. So, any other thoughts from the panelists or hosts?
Yeah, I wanted to just chime in real quick. Hanjo, thank you for joining us, and welcome to the program. I just want to clarify something. We were supposed to do this case together, but by the time I got there at 10 a.m., Dr. Kim already finished the case. Okay, so that's the truth. He was done in a couple of hours. But Hanjo, a quick question that can help us in the audience. We know the upper instrumented, the UIV is going to be high. We know the LIV is going to be in the pelvis. Talk to us just for 3 seconds about by looking at the images, how do you know if you're going to need a two-column osteotomy or a 3-column osteotomy, or do you make that decision intraoperatively?
Yeah, that's a great point. So, I think the plan for this case was to do a 3-column osteotomy, but intraoperatively, when we started doing the facetectomies, when we started doing the posterior column sort of SPOs, I noticed that the flexibility was improving. And you could kind of see that just by grabbing one of the tulips of the pedicle screws after everything's fixed and you start your SPOs. After you do this, every SPO, you kind of give it a little push and you notice that there's some flexibility there. So, luckily the gradations of the osteotomies are that you have to do somewhat of an SPO before you go to a PSO. So we had initially planned for a PSO, but we ended up not doing that because we noticed that the flexibility was good just with the posterior column osteotomy. So that's kind of how I go into a case. In full disclosure, a case like this, if I look at it, I usually say, oh, we're probably going to need a 3-column. And that's why we did it. But I do leave a flexibility for the plan in the case intraoperatively in case we're surprised.
I'm curious, are you trying to level off their fractional curve from an A-lift? I know something like this, you may do 4-5-5-1 A-lift, stage this to help level them off, or are you doing this more with T-lifts at 4-5-5-1, then just doing your compression distraction maneuvers?
Yeah, so that's really interesting question, Mike, because you'll see what I ended up doing here is in a patient without leg pain, I usually will not do inner body work for adult spinal deformities. And especially also patients who have dynamic leg pain. So sometimes you see a fractional curve that's really severe. The patients have pain all the time. They have leg pain when they sleep. They have leg pain when they walk. But there are some patients where they have leg pain only when they walk or stand. When they lay down, the foramen open up and their leg pain goes away. And in those patients, if I could preserve everything in the posterior column, I believe that you could just do a posterior fusion, especially because I also use BMP posterior laterally, and especially at L5S1, you could get nice decortication of the sacral ala. You make a nice cancellous bone window and with BMP sponges that traverse and contact the sacral ala to the L5 transverse process. And in the cases like this, without leg pain, I've tried to avoid interbody fusion, and that's why I'm able to do the case in like, a case like this in like 3-4 hours, because I avoid any interbody work. And that's why, Ali was saying what he said before, when by the time he got there to check out what we were doing, we were basically placing our rods down and taking our x-rays. So, Coy, should I just keep on going here?
Oh yeah, please. Yeah, thank you. Thanks for
So-
letting us interrupt.
Yeah, so absolutely. So here, when I'm thinking about interbody work, we talked about this, but this is the general scheme I use for what we could get. I think most deformity surgeons know this. You get an SPO, posterior column, 11 degrees of correction, PSO 30 degrees. If you do an extended type, I think I could get about 40 degrees. In the VCR, it's really, you get a ton of correction, up to 70% correction for really bad deformity cases. So here, basically what we did is I noticed intraoperatively that I took my first x-ray and the balance wasn't perfect. So what I did was I took out my rods on one side, I loosened all the fixation points on the contralateral side. And then what we did was I placed the offset iliac screw, and I placed this iliac screw with this construct here to distract on the left to make more distance and to optimize the coronal balance. So Larry Lenke talks about this, calls it the kickstand rod, but I learned this technique actually a really long time ago from Dr. Ohenaba Boachi. He used to do this for isola constructs because they weren't as the screws that they used to use back then were not as advanced as now. They would also use, for example, Galveston technique for pelvic fixation. So these are some of the things that he had taught me initially. And it works really well. So I was able to titrate the correction that we needed on the left side. Once that was adequate, I tightened all the fixation on the right side, and then we got this X-ray intraop. I was happy with this this alignment, and this was our initial X-ray before I did that round of correction. So you could see here, basically unacceptable what I think. I mean, definitely better than pre-op. And I will honestly tell you that I have seen some of my deformity colleagues say, oh, well, it's much better than pre-op. She's not going to notice the difference. And they would leave the OR with this sort of alignment. And to be honest, the patients are probably happy for the first couple of months or year or two because they are much, much better. But eventually these patients will come back with complaints of coronal plane imbalance that need to be corrected. So this is a technique that has helped me a lot to optimize that coronal balance to where the patient needs to go to. So this is the patient now, almost about 3 years post-op. This is the alignment. You could see, Mike, the extent of posterior lateral fusion here. It's like candle wax fusion. I used a combination of BMP in addition to a fresh frozen femoral head allograft, as well as autograft from the facetectomies and spinous processes to achieve this kind of fusion.
Hey, Hanjo, can I ask you a question? Quick question.
Yeah.
Hey, I think this coronal plane decompensation, I think is a really great point. And I'm just curious, in your experience, let's say I think sometimes it's hard to really pick that up intraoperatively, and, we just got this new like 3-foot intraop digital Scully X-ray machine. It's great. You can see that, but let's say you don't really pick it up and maybe some time has gone by, you see that patient, 6 weeks out, and you see that, what's your threshold for like going back in and revising and trying to modify that? That I've
Yeah.
always wondered, like, what's your threshold for that after already putting them through such a major operation?
Yeah, so that's a great question. So I have done it in multiple permutations. So one, most of it, it's all based on the patient's clinical complaints. So if they come in at their 6-week follow-up and they say, you know what, I feel better, but I also feel like I'm leaning over to one side, I'll look at the x-rays and I'll say, okay, well, I think we need to optimize your coronal balance. I could remember a case that I did about 3 or 4 years ago where I took the patient back to the OR 6 weeks later. I opened just the distal portion, and with compression and distraction of just from L4 through S1 and the iliac screw, I was able to optimize the balance. She was off by about 3.5 centimeters, and I got her to 0.5. So not zero, not perfect, but definitely good enough and within the sort of error for her not to even notice. So she appreciated that I did that. So I've done it that way. The other way that my point there is that it's based on the clinical complaints. If she came in at that time and she said, oh, I don't really feel like I'm listed over to one side or another, then I would continue to observe. But I just want to warn everybody out there, if you do these cases and you leave patients like 4 centimeters off, they'll eventually come back to get you, because what will happen is 2 years later or 3 years later, they'll say, you know what, initially I felt really good, but I noticed like when I sit, I'm leaning over to one side, or like my family says, oh, why are you still leaning over here? And things like this. And it bothers them. And when you try to revise them 2 years later, 3 years later, unfortunately, a lot of the times it's like, you're going to have to do like an asymmetric PSO at L4. And I remember one patient that I did about 7 years ago who had a pretty bad deformity, ended up doing a T3 to T4 to pelvis, and he was off by about 3.5 centimeters. He also weighed, his BMI was also about 50. And because his alignment was much better, he felt better about himself. He ended up losing a ton of weight. He got his BMI down to 30. But guess what? After he loses his weight, he notices his deformity more. So he came back. It was like 2.5 years later, and I ended up doing an asymmetric PSO for him at L4 in order to do the alignment. So for me, it's all based on the patient's clinical presentation.
Hanja, this is Matthew Goodwin here, WashU. Obviously, beautiful result here. Quick question here. So for your final construct here, I see you have 3 rods down at the bottom, and then I see it looks like you have a cross link at the top. Do you mind just talking for a minute about how you think about this final construct and if you're using titanium versus cobalt or a combination and those sort of things?
Yeah, absolutely. So this is an all cobalt chrome construct. And the reason why I placed 3 rods here is because I'm not using any interbody. And when I'm not using interbody, I feel like the rods are there. It's a race between achieving fusion versus the rods breaking. So I like to use the 3rd rod because I feel like it gives me a little bit more time while that posterior lateral and posterior fusion mass really gets solid. The other thing that it really helps with is that I place that 3rd rod after all my bone graft is in. So that is the last rod that I place before I place a drain and start closing. And the reason why I also like that is because where that rod is located, it's basically pushing down all the bone graft that I placed within the facet joints. It holds it down really nice. And because of that, some of these CT scans that I get post-op, you'll see like solid, really, really thick fusion masses throughout all of the posterior facets. And I do that, and I try to make it span through the thoracolumbar junction and L5-S1. So here, I don't place that offset, that open domino at L5-S1. I place it distal to S1 because I feel like if I placed it at L5-S1, it would be a stress riser for breaking at that segment. The cross link up there is purely there because this patient was done during a time when I was tethering patients for PJK prevention. And not that I'm a proponent of that because it doesn't work. I mean, at least for me, it doesn't work. And the patients that I looked at for my series, it was like 88 patients we looked at, and it ended up not really making a difference. So since then, I don't really use this technique. And the reason why I use that crosslink is I tie the tether to the UIV +1. And then I tension the tether by distracting a little bit on the crosslink.
Hey, Hanjo, thanks so much for those comments. I'm going to relay some points from the participants here, which you've already partially addressed. But as you can imagine, it's probably going to come up a lot, and I'm sure you get asked that question a lot, because there seems to be kind of a pendulum swing towards more interbody, say at the L5-S1, whether through an A-lift graft or a posterior T-lift graft, but basically some kind of interbody fusion at L5-S1. And I know you mentioned it earlier, but can you just reiterate to everyone what your cutoff is, what your thought process is, and what people can take home? To be honest with you, I'm like you. I don't do a lot of L5-S1 interbodies if I'm doing a multi-level construct, but I have faith in the fixation. But it is a very popular thing to do now for these. So, and it has been. So can you just comment on that one last time for everybody?
Yeah, so, the posterior interbody work. So I actually have some data coming out from my series of these patients trying to say that you really don't need L5-S1 interbody work. And the reason why I stopped doing interbody work is because early on in my practice, I started to notice that I would get rod fractures on 2-rod constructs. And guess where I would get them? I would get them at the levels where I did interbodies. And I'm like, wait a second, this doesn't make any sense. Why is this happening? And the problem that I noticed from some of my colleagues who do A-lifts and laterals is that the cost of doing a lateral and an A-lift is really expensive, because you know what? It's not like it's not like, you could say you save money because you have a lower risk of pseudo, but I could argue that that's not necessarily true in the literature. Also, every time you place an interbody, whether it be an A-lift or a lateral through an anterior approach, you're like parking a Hyundai inside the interbody. Cost is really high. And everybody usually uses a BMP sponge within those anyway. So if you were to calculate the total amount of BMP use from this construct versus the anterior posterior alternative, I actually would say I probably use less BMP, because those people who are my colleagues who are doing anterior interbody work for this, they're also using BMP posteriorly. So, so the reason why I don't always use L5-S1 interbody, and I do sometimes, but not always, is because in a case like this, where the patient has no leg pain, I did not have to do an extensive laminectomy or a facetectomy or a foraminotomy that was going to compromise my posterior fusion.
Okay, great. Thanks so much.
All right. So take-home points here, guys, is I do not leave the OR with suboptimal alignment, because even if you leave the OR and the alignment looks perfect, there are many times when you get the X-ray when they're standing post-op and you're like, why are they listed over a centimeter? Usually subclinical, but that's why I try to leave the margin of error as small as possible. Also, have some tricks up your sleeve if you want to optimize balance. So the kickstand rod is one option. You could do en bloc corrections, compression, distraction, all those things are at your disposal. I'll go to the second case, a 62-year-old lady who basically presents with low back and thigh pain. And she basically has noticed a decrease in her walking tolerance since 2015. And she had surgery back then. She underwent a L4 to S1 decompression and fusion. And she initially felt okay, but overall, she noticed that some of her symptoms, especially her back pain, didn't really improve. Her walking tolerance started to get less and less. She previously could walk over 10,000 steps a day, but now she's less than 100. And she also feels like at the end of the day, her back is really tired from everything. Her exam is pretty unremarkable, except for some mild psoas weakness. And here are her standing X-rays. So AP and lateral X-rays shows the prior instrumented fusion from L4 to S1. Her sagittal parameters are here outlined: pelvic incidence of 75, pelvic tilt of 28, sacral slope 47, lumbar lordosis of 60. So her PILL mismatch is about 15 for a 62-year-old lady. And her L4 to S1, I'll point out, is about 20 degrees under the setting of a PI of 75. And her SVA is positive at about 11. So here's a CT scan. You see, even on the supine image, not much change in that lordosis. She's got some vacuum disc phenomenon at the level above at L3-4 from her prior fusion. You notice the laminectomy defects from her prior surgery as well. And you can see here, she has a significant amount of central canal stenosis, left worse than right, with lateral recess stenosis, some joint effusions at the L3-4 segment. And so some things I wanted to talk to everybody here about is, so she basically has a L3-4 spondylolisthesis, adjacent segment degeneration, stenosis, and she has this problem. And my question to the group and to the hosts are, do you consider this patient a surgical candidate? Do you think the patient has sagittal imbalance, given that the PILL mismatch is only 15 degrees? And if so, if you would dedicate this person as an operative candidate, what kind of surgery would you do? Would you do osteotomies? What approach would you do? And what's your final goal of correction? So maybe I'll put it to the panel.
Hanjo, was her supine and standing lordos the same?
Yeah. So here is CT scan. You can see when she's supine, those are supine images. And this is her standing X-ray. So her lumbar lordosis is 60 on the standing X-ray. And this is the supine image. So pretty similar.
Great. Why don't we pick on
the supine though, is that the spondy does reduce at 3-4.
I'll make a few comments. I mean, this is a good case. That was very kind, whoever said people like me that do lots of deformity. I certainly am not the deformity person here. I'm just trying to learn from these guys. I think, at least when I look at that, I mean, I do think they're an operative candidate. I guess that's the answer here since you're showing it, but maybe it's not. I guess the thing that jumps out and the thing I'm thinking real hard about is they have this misplaced lordosis, right? They're missing, they're so flat, 4-1 or 20 degrees, 4-1. And so, I think when you correct them, it looked like they were fused through there. It's still hard for me to imagine a great result without creating more lordosis lower down in that 4-1. So I'd be thinking real hard about, a low PSO down there to get that.
Great points there, Matt. What levels would you do for your UIV here?
You probably, that's a good question. I don't know that I would necessarily be going all that high. I don't know that you have to go that high. I might actually be stopping lower thoracic here.
And so how about for some of the MIS surgeons here, like, do you think this patient's a candidate for an ACR? If so, what would your UIV be if you did an ACR at 3-4? Anybody? Or no ACR? Bad idea.
I think, I do some MIS surgery. I think that if you're able to get some, well, first, no, I would not do an ACR here. I think, to Matt's point and to yours, L4 to S1 should, I think, have, 60% of someone's lordosis, and here it, doesn't have nearly that much. But, if you look at all the levels above L3, alignment looks good. All those disc spaces looked fine. I wonder if you did your, PSO a little lower, for example, on a challenging case, but like, for example, an L5 PSO, if you could stop just at L3 and treat that spondy.
Yeah, that's like a minimally invasive approach, right? Because you're only doing short fusion. Any other comments? I'll just show what I did here. So basically, exactly as Dr. Goodwin mentioned, this patient is essentially a flat back patient. If we look at some of the literature, looking at the distribution of lumbar lordosis that I'll go over, she basically qualifies for that. And she did have adjacent segment degeneration at L3-4. So obviously we know the relationship between PI and lordosis, but it's not just PI to LL matching that we have to pay attention to. We also have to pay attention to the distribution of the lordosis. So basically what we know is that anywhere from 58 to like 68% of your lumbar lordosis should be coming from the L4 to S1 segment, Matt, I know you're at WashU, so don't tell Mike Kelly this. He's going to be upset. But this is what we've seen through some of the data. This is a paper from Virginia Lafarge. And everything we know about sagittal alignment right now is either from Virginia Lafarge or Pierre Roussely. So this is basically what told me that this patient is a flat back patient. So exactly as Dr. Than pointed out, I ended up doing an L5 PSO and fusion from L3 to the pelvis. So here are post-op X-rays, AP and lateral views. You see a good restoration of the distal lumbar lordosis and the overall alignment. You notice that the overall lordosis is still similar to pre-op, but the L4 to S1 alignment is much improved, and the SVA is markedly improved just with the correction being down there, even though you didn't appreciably change the overall lumbar lordosis. And so this is a case that I actually did recently, but I thought it was interesting to discuss because I thought there'd be multiple approaches. You know, I think we presented this at our indications conference at HSS, and some people said, oh, well, why not just do an ACR and then go posterior, try to get 30 degrees there. But that approach, I'm not necessarily a fan for as well, because you're just basically artificially forming a significant amount of lordosis higher up. And there's some data to support that that also is a high risk factor for significant junctional kyphosis issues down the line. So this patient is actually about 4 months post-op. This is her lumbar spine film after the L5 PSO. And you can see here, I was worried about overcorrection. So if you look at this L5 PSO, this is a partial L5 PSO. So I took about 3/4 of the pedicle, but the superior part of the pedicle I left alone. This little arch over here is just the iliac crest, but you see this little line right here, a little bit of the L5 pedicle is left superiorly. And the reason why I did that is because she is 62, and my concern was that if I did a full PSO on her, I would probably overcorrect her and it will lead to problems. But so that's why I did like sort of a partial PSO here. But nonetheless, because of the location of the PSO, I was able to generate enough correction here. And you could even see on this lumbar spine film, I'll get full-length Scully films at my 6-month visit, but here you could see even the improvement of the pelvic tilt from pre-op to post-op just with that lower PSO. So my take-home points here are that in deformity surgery, you really have to understand nuances of alignment and stay up to date on the literature. Even now, we started generating some data and abstracts for this year's abstract season. And what we're noticing is that there's additional nuances that are coming out as we learn more and more about alignment, especially the relationship between pelvic tilt and the distribution of lumbar lordosis and things like that. So I think we have to understand those nuances as they come out. And then also, I purposely did not go high on this patient because I wanted to preserve motion segments. And when I think about UIV for patients like this, I always consider what would I want for myself if I was in that situation. And obviously I would want to try to preserve motion segments as much as possible.
Great result, Hanjo. We should have you switch over to our MIS group in the ISSG now.
Yeah, pretty small approach there, right?
Can you talk about the use of crosslinks in your final construct? I know in the past decade or so, crosslinks have sort of fallen out of favor.
Yeah.
But can you talk about when you use them in your practice?
Yeah, I usually don't use crosslinks a lot, but the reason why I use crosslinks here is because it was a short construct for a significant amount of correction that was done. And I wanted to add some little bit of stability that I could. The other time I'll use a crosslink is, if I am, for example, tethering and I want to, use it as a tension device. And then sometimes in like a single level fusion, like L4-5 degen spondy cases, and if the bone quality is really poor, I will use a crosslink in those cases as well, because I just feel like it'll provide a little bit more stability. But other than that, I really don't use crosslinks much.
Great, thank you. Any questions or comments from the other panelists?
Yeah,
I'm curious how you manage neuropraxia in these patients. If you're doing such a low PSO, are you ever running into kind of these MEP negative foot drops where you see no monitoring changes, and 4 or 5 days later they get a 2 out of 5 in their dorsiflexors? How are you managing those?
Yeah, so I have not yet seen a L5 nerve root issue from L5 PSOs. And I think honestly, I've done about 8 of them now. Like I know a lot of people are always saying, you know, be worried about doing L5 PSO because you'll run into L5 nerve root issues. When I do these cases, I will completely free and visualize the entire course of the L5 nerve root. And as I do the correction, I'll keep an eye on the nerve root. And if I see it tensioning, I'll stop. But most of the time when I'm starting to close these down, I actually see them getting looser. So although L5S1 high-grade spondy cases, we see the L5 nerve roots when we dissect them out and they start to get tight. I have not seen that for L5 PSO cases. So, you know, I think, you know, the question is, what would I do if I had one? Well, if I had one, I think it depends on how dense it is. If it's like a 4 out of 5 foot drop or like a 3 out of 5 that doesn't need an AFO, I would probably observe it because the likelihood is that it will get better. It also depends on if the patient has pain. If they have pain with the neuropraxia and the weakness, I'm more likely to go back to try to do something. But if the patient has painless weakness and from something like this, I would probably observe it as long as they still have some function. Now, if it's like a 0 out of 5, I would definitely go back and try to undo something and try to get it back. But you know, some of our data from neurologic complications, even from the ISSG, shows that if they have partial weakness, usually they'll recover by 6 months to 1 year back to complete function, at least about 75% of the time. So that's not bad odds, I think, to hang your hats on.
Thank you.
Yeah, hello, Hanjo. Alexander speaking from Switzerland. It's really impressive. It's really amazing results here. I have a question. How do you treat patients with obesity with a tendency of ankylosis in the thoracic spine? For example, in this case, how much segments will you leave not fused? Because I have seen many patients with the same attempt not to fuse too much, but then at least only 2 segments were moving and there was a fast degeneration.
Yes, that's a great point. So if this patient had ankylosis anteriorly, there's probably a couple of things I would have done differently, especially if, like, let's say they were ankylosed from T12 up to T5. I've seen those patients do exactly like you're saying. So those patients tend to have some kyphosis. And when I do the corrections for those patients, I have to consider the thoracic kyphosis as a part of the rigid deformity. So if this patient had a fixed kyphosis with anterior ankylosis, I probably would have done like a T10 to pelvis, but I would have done a full PSO and overcorrected the lumbar spine a little bit, not completely, but here I came to like a 60-degree lumbar lordosis. I would have aimed for like a 75-degree to match the PILL, depending on how much kyphosis there was in the thoracic spine, because otherwise, if you try to undercorrect while there's hyperkyphosis above, you'll result in a positive sagittal imbalance, and the patients won't like that. So in those cases, I always, if they're fused and ankylosed in the thoracic spine, I will consider that into my calculation for how much correction I'm trying to get below. All right, so now I'll get to, how are we doing on time? Coy, we're okay?
Yeah, we're doing well, Hanjo. I think we got about 20 minutes left. So let's see how this next case goes. And
Okay, great. So here's case number 3, a 68-year-old lady. She's got back pain. She feels like she's leaning forward, no leg pain, but she had this surgery done at outside hospital in 2010. Obviously had a high-grade spondy, but the surgeon that had done her operation before just did an in situ fusion there because I was obviously a deformity above and then try to do this deformity correction. So now she presents, I think it was about 7 years later, with broken rods. And you could see here close-up AP and lateral X-ray. There is an extensive fusion mass here, but obviously a pseudo present, a construct here with unilateral iliac fixation and what looks like what might have been trans S1 L5 screws to try to stabilize that high-grade spondy. Here are the supine scout CT. So you could see how rigid the deformity is. It looks just like the standing X-ray. And of course, when I'm planning for this, I'm going to say, okay, I got to do a big operation here and probably is going to need a 3-column osteotomy. Here on the CT scan, you could see where that trans S1 L5 screw went. You could see vacuum disc phenomenon, which would be at 5, 4, 3, 3, 4. And so that hints to you that that's probably where the rod is breaking because of the pseudo at the 3, 4 segment. And sure enough, if I follow this CT scan out through the parasagittal images, you could see a line here of unhealed bone, likely the area of pseudo, area of the rod fracture here. So it tells me that probably the L3-4 facet is not fused. Patient likely has a pseudoarthrosis that's now symptomatic, 7 years post-op. To add to everything, this probably didn't look like this when the patient had the initial surgery, but for whatever reason has PJK. Some of the screws are pulling backwards a touch, and here it's probably touching the cord a little bit. Still a lot of CSF there, so I'm not sure if there's frank myelopathy from this at this point, but nonetheless something that I'm going to consider to revise if I'm going to take this patient to the operating room. So the question here to the panel again is, what would we do here? What approach? There's a L3-4 pseudo. Will we do a combined anterior posterior? Do we do an inner body at 3-4 anteriorly and then just go in the back and lock everything in and then fix the PJK? Or do you try to do anything a little bit bigger, like address the L5-S1 spondy and the sagittal plane imbalance here that you see? And things like this, how high would you go if you fix the PJK? So I'll open it up to the panel here to see their thoughts.
Yeah, Hanjo, this is Ali. Thank you. I'm glad you mentioned PJK because I was definitely going to ask you about your techniques and tips and pearls for that. It's interesting to see that you're not a believer of the tether. So we'll chat a little bit more about that. But I think if you're going to commit this patient to the OR, I would definitely address both. I think they go together. The top and the bottom go together. You can't fix the top without the bottom, and you certainly can't do it vice versa either. So my vote, I'm sorry, I was promoting our February 12th course, so I didn't see the CAT scan or the fusion down below. Is this patient fully ankylosed below?
Yeah, so it looks like the high-grade spondy is in situ fused at L5-S1, but you can see the vacuum disc phenomena here at 3-4, and then the corresponding facet line here, where you can see the pseudo line where the rods are fractured.
Yeah, I think I like that trick of looking at that vacuum disc on CT. I've learned from you and others that you can do a lot there at that level. There's it's amenable to osteotomies, to inducing lordosis at that level. I've also seen people, I certainly have not I have not done this, but I've seen folks do the S1 PSO that will solve this problem right away. But I think you can potentially take advantage of that L3-4 level for your 3-column osteotomy and then fix the top at the same time.
Nice. Anyone else?
Yeah, I just would say, I mean, this is obviously a super hard case, so I'm can't wait to see what you did with this. But I agree. I think fixing everything is the right thing. I think you can't leave the PJK like that. I think you have to address their balance overall. And I think if you have a level you can work through, I guess I'm tempted to think about that S1 osteotomy, but gosh, I don't know. I mean, if you can get something working through the level where you have a disc that's going to move for you and put a little graft in there, that'd be nice as well.
Great. So just for the sake of time here, I'm going to go to the what I ended up doing here. So I actually did a revision T2 to the pelvis with a S1 PSO. So you can see here the alignment change with the S1 PSO. You could see for the S1 PSOs, because of the you could only get 4 iliac screws distally. Maybe you could get 6 if you really wanted to, but I worry about stability there. So I put an inner body into the PSO site to aid in the bone-on-bone opposition. There you could see the inner body there. Address the PJK with a single level SPO at that segment, took those screws out, and then extended the patient 2 levels above. So she's about 3 years now post-op, doing very well, sends me Christmas cards, was very happy. One little tip about the S1 PSO is that you basically, in doing the S1 PSO, also have to take a significant portion of the sacral ala. Because if you don't, then what happens is as you close down the PSO, the L5 nerve roots will get draped over the sacral ala, and they start to get tight. So whenever you do these, you just have to make sure that you do the dissection all the way out through the sacral ala, and take a portion of it with the PSO. Any comments?
Did you consider not doing the S1 PSO, or were you pretty convinced you weren't going to get an acceptable result without doing it?
You know, so I had a plan of maybe I'll go in there and see what the L3-4 segment looks like, and if I could get more correction over the 3-4 segment to fix the sagittal balance, then I'll try to do that. But I thought to myself, like, yeah, there's like an 80% chance here. I'm just going to go with the S1 PSO. Interestingly, it looked like here it was a pure, like, whoever was doing the case before was just rushing through the case, because when I got down to the L3-4 segment, there was no facetectomy performed at all. So I did a facetectomy. There was a nice cup of SAP, and the remaining after the IAP was resected. So then it was really nice fusion surface, because basically I burred down that whole thing, had a bunch of autograft, and I put a BNP sponge in there. So I was like, okay, well, that's how I'm going to address that segment now. And then I focused on the S1 PSO.
Oh, it looks awesome.
So this patient, I was initially very, very worried about, because she didn't have any weakness, but she had burning down her legs for like the first 4 weeks. Also had burning in her back. And I was really concerned. I was like, you know, we checked up on her all the time. I was like, are you feeling any foot drops or anything? She had nothing like that, luckily, but this is the closest to like a neuropraxia issue that I had. But, and the other thing about her is normally patients after a PSO like this, I'm not sure what everybody else's experience is, but they bounce back pretty quick, because a lot of the time PSOs are done in prior fusions. You cut the bone out. They're kind of quick cases. This one was a little bit longer. I think it took me about 6 hours to do the whole thing, but I was worried about her because she had this burning pain in her back, low back, and she also had this burning pain down her legs. And I was like, man, maybe I'm going to have to go in there and revise something. But when she came back, so at the 6-week follow-up, this is what she still had, those symptoms. But when she came back for her 3 month, I had her come back a little sooner than the 6-month follow-up. I had her come back at 3 months. All that stuff had gone away, and she was feeling like really, really good. By the time I saw her at 6 months, she was like, man, I never knew I could feel this good. Even after my prior surgery, if I knew that this is how I should be feeling, I would have told the surgeon, like, something's wrong. I need to be fixed, because the patient, you know, even before this rod broke, she still had this coronal decomp. She still had this sagittal imbalance, and she was definitely better than before, but just not just not where she wanted to be. So interesting case, I think, to think through as far as what we would do and the patient's post-operative course.
Great result, Hanjo. You know, not only is the sagittal correction really good, but so is the coronal correction. So did you have to sort of asymmetrically do your S1 PSO?
No, I did my S1 PSO very uniformly here, but when I did the correction with the cantilever bending down, when you first fix the distal fixation points and you cantilever bend the pelvis down, I led with the right side, because I knew that I had to basically bring the pelvis towards the right to bring it underneath her trunk. So it was just the side that I just led more with.
Hey, Hanjo, that's a great result. I got a question for you with the low lumbar and also the S1 PSO. What are your thoughts about doing arthrodesis across the sacroiliac joint because of the lack of, not having so many fixation points, whether it's with, these devices or whatnot. What are your thoughts on that?
I don't have anything academic to comment on that, but we are studying it now because I'm one of the centers for the SI bone randomized controlled trial on SI fusion during these reconstructions. So we'll see what the study shows, but I'm not 100% convinced that you have to do it. I mean, I'm interested in seeing the data wholeheartedly.
Yeah, to your point, I'm involved in that Sylvia study as well, and I think Bobby Slack guy and a few others have a ISSG paper coming out soon showing that pelvic fixation actually loosens probably in about 25% of cases. Now, that might not all be symptomatic, but the fact that things are sort of wiggling around in there, even if they're putting in 10-0 by 100 screws is I think a cause for concern. So will be great to see what the Sylvia trial shows.
Hanjo, I have a question. I've heard that at the HSS, the surgeons are really masters with the chisel. So do you use for your osteotomy a chisel, or do you use a bone scalpel or a drill or a kerosene? What is your tool?
I use the osteotome all the way.
Osteotome, like a chisel osteotome?
Yeah. So I have various sizes of the osteotome. But sometimes if the space is very small, I'll use a 1/4-inch osteotome. It's very, very thin. You could be very precise with it.
I love using them too. And I think the blood loss is less. Can you comment about blood loss?
Yeah, I agree with that. I think the blood loss is less. The other thing is, after you're done with the osteotomy, because you're not using a burr, you have a ton of autograft bone. And it's great autograft bone because it's all cancellous bone from the vertebral body. So I'm a big proponent of using osteotomes, not using a burr for these osteotomies.
I think the HSS is famous for that.
Yeah, I didn't know that was, but thanks for pointing that out. Yeah.
The fellows who come here back are really good at with the osteotome.
You say, yeah, nice, that's cool.
Well, Hanjo, we have about several minutes left, so why don't you take us home with your last case?
Great. So anyway, so take-home points for this case is when in doubt, an osteotomy should be done at the apical segment, that case that I just presented. And in the sagittal plane, if you could avoid it, you should always try to achieve balance by not creating deformity to balance the deformity. So the reason why I say that is some of my colleagues who I presented that S1 PSO case to, they told me that, oh, why don't you just do a PSO at L3 where the pseudo is? But that would have been like a hyperlordosis sort of thing up there, and trying to balance that would have been sort of, I think, interesting to try to say. But the reason why I show this case here is because here it's a coronal balance issue. So you got to in situ bend. You have to sort of create deformity in order to achieve the balance. But although that's the case for the coronal plane, I think for the sagittal plane, it's a different way to think about it. So here's case number 4. 16-year-old female who has a 130-degree deformity, kyphoscoliosis here. You can see here pretty bad looking curve here. She's actually an idiopathic because she doesn't have any syndrome. She's an otherwise normal person who just basically had a deformity that was not checked up, neglected. You can see here on the bending images, really that apex is not moving. Here are some of the bolster films, like I told you, Mike, that we do at HSS for the peds patients. But here, very stiff deformity, as you could see. And CT scan showing some really stiff, really small pedicles along the apical segments there, very small pedicles. And you can see here on the CT scan, pretty question mark type deformity case. So here, the questions to the hosts are, what are our options here? Do we do a front back operation? Do you do pre-op traction? Do you do anterior releases and then pre-op traction? Do you do a 3-column osteotomy? And if so, where do you do it? What's your planned UIV and LIV? And do you think it's necessary to do any rib work? So I'll open it up to the panel.
Without a tumor, this patient would not make it past my partners to me. So I'm happy to defer to the others here.
How old did you say the patient was, Hanjo? This is a teenager?
16, yeah.
I mean, I don't have a whole lot of experience doing pre-op traction for a week or two like you guys and Lanky would beforehand. I'm not sure if this might be a candidate for doing something like that. However, it looks like it's a pretty stiff curve. So in my practice, if I had a heinous deformity like this, I probably would not do pre-op traction. I'm thinking of doing an apical VCR as something like this, and probably doing upper thoracic to probably mid lumbar on something like this. and maybe even doing one of these construct to construct, techniques that you talk about, where you kind of put one of these dummy rods in, do a lot of in situ bending, and kind of a lot of rod swapping out until you finally get your final rod in place.
Nice. I feel like you've seen me give this talk.
Yeah, I agree with
I've seen
Michael.
you
I
give
think
you.
this issue, Andre, actually comes up a lot. I know we only have a few minutes, but the idea of preoperative traction comes up a lot in these sessions. I can tell you that I agree with Michael. Apical VCR, T2 to probably L3. That's a given. The real question is the utility of preoperative halogravity traction. Do you have the means to do it at your institution, and is it truly beneficial for the patient or not?
Yeah. I mean, those are good points, because not everybody has like a spine hospital like Larry, where you could house these patients for like 6 weeks and stuff like that. So, I'll, just for the sake of time here, I'll show you what I did here. So when I do a VCR, just like Mike said, I do this en bloc correction. And the reason why I do that is because all my correction goes on this outrigger rod here. And the VCR site is somewhere like this. So this is not this particular case, but just shows you the setup. And the reason why I like to do it this way is because if at any point during the correction, if you lose motors, you could easily just loosen up that domino and distract and get back to where you were before and try to get the motors back. If you go rod to rod on each side, every time you place the rod to the other side, there's a 3-dimensional change in the spine. And if you lose motors, you are sort of screwed, because you're like, okay, I got to get that spine back to where it was before, where I had motors. And so this is the technique that I use. Here's a video showing like basically the kind of correction. So first, this is like the correction that you could achieve with the in situ bending portion. And you could see here, like you basically could, I place that in situ bender sort of that way instead of the other way, so it could only slip out laterally, not medially. So it's a safety issue. But once you place the in situ bender, you could achieve a decent amount of correction. So here's the VCR site. You could really achieve a significant amount of correction of the kyphosis. And then for the coronal plane portion, here you could bend off of this as well. But the first thing I do is a round of compression. So you go back doing compression to shorten, and then the in situ bending to get the correction, and then you shorten again, and then the in situ bend again. You could basically do this 2 or 3 times, maybe even 4 times before you get the correction that you want. And the shortening allows you to really play with the spinal cord and what you don't want to do is try to do the correction before you compress. And the reason why is because that'll result in a stretching of the spinal cord, and you'll get motor changes. So here's what I did. I did exactly what Michael said. I did a T9 VCR here. I also did a thoracoplasty and concave rib osteotomies and Pontes above and below to achieve this sort of correction in the AP and lateral plane here. You could see the alignment, also significant improvement in the rib hump. So, the take-home points here was that basically I believe at least that the en bloc correction is a safer technique, at least in my hands, than going rod to rod for these VCRs. It also doesn't compromise your fixation points, because a lot of the times when you're compressing and distracting on single fixation points, even if you have a long rod, they start to loosen. This distributes the stress along the entire construct, so you really have less problems with loosening of your screws. And then as you do this correction and the spine gets more and more corrected, you'll notice that, oh wait, it's getting a little bit harder for me to get my correction here. And what's going on there is that something within the deformity is tethering your correction. So you always have to keep an eye on not having the tunnel vision, but also looking at everything else. So that's why I decided here to do the concave rib osteotomies, to do the thoracoplasties, because I noticed that as I was getting the correction, the ribs were getting more crowded. It was holding me back from getting the correction that I needed to. Also, sometimes I don't use cable traction for this, but I've had colleagues who say, I don't know what's going on. I can't get my correction. I come in to help them. I notice that they have skeletal traction on and it's pulling on the spine, so they can't really compress enough. So I tell them, take all the traction off, then you could get the correction. So all these things should be considered when you're doing a case like this. So this is a summary of my take-home points. If any of the participants want to take a screenshot or something to go home with. And I really want to thank everybody for giving me the opportunity to present here today. I feel honored to have been a part of this, and hopefully I'll have the opportunity to come back to do it again. Thanks, guys.
Hey, Hanjo, that was
Thank you.
oh, sorry, someone wanted to say anything?
No, I was just going to say thank you. Those were great cases and great points to all of them. Thanks for doing this, Hanjo.
No
That's
problem.
awesome. Thanks a
Great,
lot.
Hanjo, great cases. You know, our attendance was higher than it's been recently. So really appreciate you taking the time. And John, you want to give a shout out for next week's session?
Yeah, sure. Hanjo, again, thanks. Really awesome, great cases, especially that last one. Wow. But next week, we're going to have Martin Pham from UCSD, neurosurgeon, talking about robotics. So that'll be next Thursday. So thanks again, everyone. Stay safe and good night.
Great. Thanks, everybody.
Thank you.
Take care.